Hello, everyone. Welcome to Johnny's Ambassadors Expert Webinar Series for Parents. I'm your host, Laura Stack. I'm the founder and CEO of Johnny's Ambassadors, which was formed when my son Johnny died by suicide in November 2019 after delusion from marijuana-induced psychosis. We are here to educate parents and teens about the dangers of today's very potent marijuana on adolescent brain development, mental illness, and suicide ideation. And we have a wonderful, amazing guest, Dr. Karen Randall, whom I will introduce in just a moment after we go over a couple logistics. We do have some handouts for this session. They are either on this page where you are watching this recording, or if you are live with us right now, they are in a section called handouts. They are a PDF of Karen's slides, as well as several research studies, which she kindly provided to us. This session is also being recorded, and you can share it with the URL of the link where you are watching it currently. We are taking questions. Dr. Randall will be saving some time at the end of her presentation to do Q&A. So you'll see in your control panel, there's a box that says questions. So please type them in as you think of them so that you don't forget them when we get to the end of the presentation. GoToWebinar platform is having some challenges on Karen's end. She's unable to show her webcam today, so I will be advancing her slides. So I will do her introduction, and then we will ask her to come on, and you will see her or hear her and see her slides. Dr. Karen Randall is an emergency medicine physician. She has had residency training in family practice, pediatrics, and emergency medicine. Prior to moving back to Colorado, Dr. Randall taught residents and medical students at a large teaching hospital in Detroit. She currently practices emergency medicine in Southern Colorado, where she is the vice president of case management for the emergency department. Dr. Randall has a certificate in cannabis science and medicine from the University of Vermont. She has served as an expert panelist for SAM HSA SAMHSA in DC, testified to many legislators, and spoken at numerous conferences and meetings, including parliamentary members in Australia. Dr. Randall is the co-president of Parents Opposed to Pot. Dr. Randall, thank you so much for being one of Johnny's ambassadors. Welcome.
Oh, thank you for inviting me, and I'm sorry that my computer is not playing well with the platform here.
No worries.
Today, and I hope everyone can hear me, today we're going to talk about what we're seeing in the emergency department with regards to cannabis. And basically, this is why I speak out, because I see the harms every day. Again, I took the time to get certified in cannabis science and medicine because I kept hearing about it, hearing about cannabis, and I kept wondering, there's got to be something that I'm missing. So I did get certified in cannabis science and medicine, and I'm still wondering what I'm missing that makes it such a great thing. If we could go to the next slide, please. So first and foremost, I want to say I have no disclosures to make. And anytime you listen to anyone speak where they're talking about something like this, you got to hear if they have disclosures, because obviously their opinion's going to be swayed. If I had investments in a cannabis business, my presentation might go differently. So that's why asking for disclosures is very important. It happens in every medical lecture when we give a lecture at a conference. If we could save the questions for the end, but if you do have something that comes up, please put it in the question box. Next slide, please. We'll talk about today the cannabis basics. And the reason we talk about the basics is because it's really important to understand some of the basics to know why it's so harmful. And then we'll talk about the emergency, some of the things we're seeing in the emergency department with regards to complications. And then briefly at the end, we'll talk about looking forward. So what are we doing to our up and coming generation and our next generations after that? So next slide, please. So it's important to know that, like, despite the fact that we call it hemp, CBD, THC, and there are hundreds of other chemicals, they all come from the plant genus known as Cannabis sativa. THC producing plants are from indica and sativa, and hemp comes from the plant ruderalis. Hemp by definition is less than 0.3% THC, and then CBD comes in a mixture from the other plants, from cannabis, sativa, and indica. Currently, the industry has genetically altered the plants so that they are high THC producing plants. When the THC content goes up, the CBD content goes down. In the 90s and earlier, or in the natural plant, there's roughly a 40 to 60% THC CBD ratio, so it's almost equal. There are hundreds of other chemicals in a plant. Some are active, some are not. The next most common psychoactive plant is CBN, the next most common product. Can we go to the next slide, please? These are the types of weeds: sativa, indica, and ruderalis. Once again, the ruderalis is the hemp producing plants, high in CBD, low in THC content. Sativa and indica have different properties when you use the product. Indica, I remember, is indica couch, so it's a sedative and it's more calming or relaxing. Sativa is more of a stimulant. Next slide, please. If we look about what's happened over the last 10 years with regards to product, in the 1960s you could smoke it, and some people would do HBO labs and make hash oil or butane honey oil. Now we have a variety of products. We have dab, wax, and shatter. We'll talk about that in a little bit. These are highly concentrated THC products. We have flower, which is typically in the smoke joint. We have vaping, again, uses THC concentrates, and we also have edibles, topicals, creams, lotions. There's also specialty products, and we'll talk about those in a minute. We have chapstick, toothpicks, condoms, tampons, toothpaste, mouthwash, all with products in them that are THC bearing. So if we could go to the next slide. So when we talk about extracts, this is basically how they're made. And the home extract is made by taking a turkey baster, a glass turkey baster. You stuff the turkey baster with cuttings from your marijuana plant, and then you run butane or propane through the turkey baster, and you collect a yellow resin, which is what's on the right side of your screen, and you let that resin dry out. When we hear about the honey oil or the explosions, it's because the process of drying, when you're vaporizing off or cooking off the butane or propane, it's very explosive. So that's the process where it will blow up. There are some companies now that extract products with CO2, which is thought to be the more organic process, but it costs a lot more money. So most products are still, the extracts are still made with butane or propane. Each state is different in the amount of remaining propane and butane. As we legalize across the states, every state sets their own regulatory guidelines. The problem here in Colorado is I don't believe, have a limit in the amount of butane or propane that can be remaining in the product. And we have so few people following or checking these regulations that it's impossible to keep up with all the companies that are making it. In addition, there's no way to regulate what's being done in the unlegal market or the black market. Next slide, please. Here's some of the products that are available. The top slide on the left, if you look, it's a live sugar hybrid, the purple elephant. It's 65.6% THC. So if you have a gram of that, you have 656 milligrams of THC. The product that's on that same slide that looks like a syringe, this was at a dispensary. I asked if this was made to be an injectable, and my answer was, no, it's not injectable. We use that for suppositories. However, I believe that it was on the market as an injectable. You can see that the concentrations vary, and we now have THC concentrates that are up to 90% THC. So this is high-potency THC. And multiple studies now have been done to show that there is actually no benefit from the high-potency THC products. If you look at the next picture over, you can see a wide variety of candy products called edibles. The next picture over, you can see that there's a vast variety of products that are available. And this picture was a picture I took at a dispensary here in Pueblo, where I'm talking to you from. There are compressed pills, there's chapstick, there's candy, there's extracts to make with tea. If you look down in the bottom right left-hand corner, you can see chocolate bars, and we push to have size dosing or dosing limits, and you can see that each piece of chocolate is 10 milligrams. The problem for us in dealing with it from this end in the emergency department is if you're 8 or 10 or however old you are, if you're a child and you're looking at a candy bar and you see that one dose is 10 milligrams, you really aren't going to stop at one square because you're not going to understand the coding, and you're going to eat the whole candy bar, which we've seen again and again. Same with when you make a brownie or a cookie, and a cookie has 6 servings. So a serving size in Colorado is 10 milligrams. If you have 6 servings, you have 60 milligrams. And if you're a pediatric or you're a child and you eat that, you've eaten 60 milligrams of THC, and you can understand how the harms happen. The next picture over is cotton candy, and then the next picture to that is a THC infused tampon. And to me, it seems that many of these products were meant to deceive. So somebody could get a THC tampon and insert it and be using product without any awareness, especially in schools. If we could go to the next slide, please. Again, looking at some more products, you have cannabis infused shampoos. This is the upper left-hand side. I'm not sure how that helps, but it's infused. And you have chewing gums, so you could chew cannabis, and if you were at school, you could simply have the appearance of chewing gum. We have mouthwash. They make THC-infused toothpicks, which is in the bottom left, and it's 100 milligrams of THC in a toothpick. We have salves. So for us, what I've seen with the salves is there's very little regulation on what goes in the salves, what they're made with, and the end product contents. And I've seen a lot of really significant dermatitis or really bad skin breakdown and skin problems following using a salve of some sort. And finally, the picture on the right-hand side, this is a hoodie, and it's set up. You can see the string of the hoodie is actually a vape pipe, and the content is then in the hoodie, so it really looks like you're just wearing a regular sweatshirt. And this is clearly a product meant to deceive. If it were open and honest, it wouldn't have to have products hidden in your hoodie t-shirt. Let's go to the next slide. So if we look at cannabis as quote a medicine, and again, I did do the certificate in cannabis science and medicine. The conclusions I came to was we haven't really ever voted on a medication to be like whether it's a medicine or not. And the public is being asked in more and more states to vote on whether they're going to use this medicine. There's no formal medicine, including the FDA cannabis approved products, that has the directions to take as much as you want, use it when and where, use as much as you want. I went to a dispensary here in town with the sheriff's department, and we came in a sheriff's department vehicle. And the owner of the dispensary said, as I looked around, and they had 10 milligram compressed pills of THC. And he said, well, these are our starter products. And I said, really, you start with 10 milligrams? He goes, no. He goes, I tell them to take a half a tablet, 5 milligrams, but I tell them, don't worry, we'll have them up to 90 milligrams before several months are out. And so if you look at that with regards to medication, there's no way, and there's no medication that I know of that says take one, but take as many as you need, or hey, we'll build you up to a whole boatload. And no medicine in my book should ever be smoked. It is years and years of effort to get people in the public to stop smoking, and we've kind of vilified cigarette smoking, and at this point now we're smoking our medicine in the form of cannabis, which doesn't make sense. And we'll talk about the vaping harms and the harms that we've seen when people vape in a little bit. Next slide, please. The other thing that we don't talk about in general to the public is the interactions. Cannabinoids are metabolized in the liver. It's called the cytochrome P450 metabolic pathway. And when it's done like that, when it's metabolized in the liver, and this is especially true of edibles since they undergo first pass metabolism, it interacts with a whole bunch of other medications that are actually broken down in the liver. And probably one of the most important ones is Coumadin. And there have been case reports of people having excess Coumadin or warfarin, which is a blood thinner, and having bleeding problems after having chronic use of cannabis. The other medications that could potentially interact is calcium channel blockers, isosorbide, non-steroidal medications, HIV medications, seizure medications, and these medications are actually all altered in the liver. And again, once you use or once you have the cytochrome P450 active, it can change the way you're metabolizing your medicines, and so can lead to interactions or complications with those medications. And this is very seldom talked to the public, and certainly when the average patient goes to the store, they're not looking at the medications. Every time I see a patient in the ER, I review the medications so that if I prescribe something, I can make sure that there's not going to be an interaction, and this is not happening. Here's a quick story that I like to tell people because it's very telling of what happens. So I gave a lecture to a bunch of nurses and providers who go out and do home health care. And I was told by one home healthcare nurse that she sees people with Alzheimer's, and because where it was very rural where she was working, and she says, I just tell the family of the people with Alzheimer's to go to the dispensary and buy cannabis. As an aside, the American Alzheimer's Society does recognize that there is some sedative effects, but absolutely does not recommend cannabis for their Alzheimer's patients because there are too many negative effects. So this nurse said she recommends that her families go to the dispensary and buy cannabis for their family member with Alzheimer's. And I said to her, I said, well, when you have them go, do you give a list of medications so that they can see what this patient is taking so they can make sure there's no interactions? And she said no. And I said, do you give a dose recommendation so that when you go there, like if I say you need a blood pressure medicine, I'm going to tell you to take 10 milligrams twice a day. I said, do you give a dosing recommendation so that you can give guidelines to the bud tender who is not typically educated, especially not a medicine person? And she said no. And I said, so the summation in my book is that you are turning the care of a potentially vulnerable patient over to someone who has no medical training at all. And at that point, she said, well, I'm still going to do it. So knowing that there's no checking of medications, there's no limiting of dosing, or there's no guidance on dosing, and that there really is no recommendations by the Alzheimer's Society, and the American Academy of Neurologists do not recommend it as well, that you have to wonder why we're being allowed to do this. Next slide, please. So first and foremost, one of the biggest things that we see is hyperemesis. This is, it can occur after an acute ingestion. It can be intentional or accidental. Oh, I'm sorry, these are the things that we're going to talk about: hyperemesis, acute ingestions, cardiovascular and stroke, vaping injuries, and acute psychosis. And following that, what we'll do is talk about what we're seeing in our future generations. So next slide, please. So cannabinoid-induced hyperemesis, CHS, cannabinoid hyperemesis syndrome. We're unsure why a certain subset of these people develop symptoms, but they do. And once they develop symptoms, the symptoms are more than likely to reoccur, and they recur on a cyclic basis. These symptoms usually develop in people who use cannabis products frequently, and it's also in the ER groups affectionately known as scromiting because it's a combination of scream, vomiting, and I have an audio. So Laura, if you want to play that. So it's kind of gross, but this is what we affectionately call scromiting. And we see this in our emergency department at least once a day. Next slide, please. So these patients will typically come in repeatedly. And when they do come in, they'll come in in a group. So they'll come in once a day for a week. They'll come in repetitively, and what they say is, you know, the vomiting is happening. They've attributed it to other causes, and typically what happens is that these patients get an extensive workup, because as you heard from the video or from the audio, that it is really dramatic when it happens. It looks very painful. And sometimes these patients have vomited enough to end up in the ICU, and there's even been recorded deaths from electrolyte abnormalities from persistent vomiting. When I had done an outreach seminar with some of the nurses, they talked about they had a young patient, like in his 20s, in hospice because he wouldn't give up cannabis and continued to have hyperemesis and basically was wasting away. I would say that of all the patients that I've seen with hyperemesis, only one has said, maybe I should give up pot. There is a very real lack of perception that this could be the harm, which is pretty amazing to me, because most of these patients have multiple ER visits, they've had multiple CT scans, they've had multiple endoscopy and other workups, and yet there's this denial that it could be their medication because they're all convinced that this helps their vomiting. And once they get cyclic vomiting, then they use more and the cycle repeats. The cost of care for these people is extraordinary, especially when you consider repetitive ER visits, repetitive medications, potential hospitalizations. There was a recent study, and this is included in the handouts, from the Journal of Addiction, where radiologists looked at just the radiologic costs of delayed diagnosis of cannabinoid hyperemesis, and their conclusion was it costs about $76,000 to diagnose or to come to the diagnostic conclusion that this is hyperemesis. There's a lot of reasons why this happens, and one of the reasons is that people are led to believe this is a miracle drug. They're led to believe that it is great for vomiting. And again, like I said, we don't know why a certain subset of people gets hyperemesis, but when they do get it, the only treatment is to stop. And so convincing these people to stop is really difficult because they don't want to believe that, and most don't. And they undergo scopes so they can rule out ulcers or other problems. They undergo hospitalization because they've altered their electrolytes, and multiple ED visits for control of the vomiting, because when they do come to the emergency department, the typical drugs used to control vomiting typically don't work. So we use drugs that are considered antipsychotics, so Haldol or Risperidol, and these actually work better for these patients. In RED, we're seeing about one patient a day. And if we just talk about the ER visit cost, so I'm going to come to the ER and get seen, it's about $5,000 to $6,000, and this includes maybe a CT, maybe an ultrasound. It includes IV medications, nursing time, physician time, and the billing is roughly $5,000 to $6,000. If we talk about one visit a day times 365 days in a year, and we'll go at the low end of $5,000, it's a $1.8 million for one institution charge over the year, and we have 25 ERs in Colorado. So you can see how this cost alone, just this cost alone, would rapidly exceed whatever tax revenue or tax benefit that you make. We're just cost shifting. So instead of taking it directly from the taxpayer, we're taking it to the taxpayer through their health insurance or their Medicaid. Next slide, please. So I'd like to just talk about a few cases that I personally have seen in the emergency department so that we can see the scope of the other problems that we have in the emergency department. The first case is a 40-year-old female who comes from out of state. So it was her husband, and 2 children in the car with them. They were coming from out of state. They crossed the border of Colorado, and the first thing they did was stop at the cannabis store that's right there at the border, and they bought edibles. Well, if you talk to someone who takes edibles or someone who uses the product, one person once told me that eating an edible is like being on a roller coaster ride. You don't actually really know when it's going to start, but once it starts, you're on till the end because you can't take the product out of you. Because the edible product will undergo first pass metabolism, the onset's typically delayed from anywhere from 20 minutes to even up to an hour. And so what happened with this patient was she took an edible, she waited a couple minutes, nothing happened, so she took another one. Waited a couple minutes, nothing happened. She took another one, and ultimately what happened was, as they were coming down I-25 at 75 miles an hour, she became acutely psychotic in the car and started yelling, grabbing and throwing stuff. The husband was able to get her to the emergency department where she required IV fluids and some sedation and a prolonged observation. And then when she woke up, she said, "Do you think the kids noticed?" And the car looked like a scene from The Exorcist, so I'm pretty sure the kids noticed. But imagine if you were a family member and you let your 12-year-old child go with their family friend on a ski vacation, and this is what happened. And we see this kind of pattern a lot. I saw a 72-year-old female. She was visiting from back east, and her son was a bud tender, and so her grandson was a bud tender. So they decided that they would get grandma high, and she was kind of seemed like a very tough old lady. So again, they gave her edibles, and this lady came in at 72, extremely agitated, screaming, yelling, having hallucinations. She required sedation. She required prolonged evaluation, and ultimately was discharged home with family, but not after incurring a moderate ER charge and a long, prolonged ER stay. The next case was a 42-year-old female who presented like a stroke. So she was completely not responsive, except she had her eyes open. She was brought by the family for evaluation. She was essentially not responsive. She got a costly stroke workup because it's on us to determine that this is being caused by a drug as opposed to it being caused by a real stroke. And so she got head CT, head and neck CTA, and a neurologic evaluation. And ultimately what happened was the family took out a bottle, a dropper of THC tincture, and I don't know if it was 60 milligrams per dropper or per half ml. The dosing wasn't labeled, but it was highly concentrated, and apparently she had took quite a bit of that. So she got an expensive ER stay, she got a prolonged ER stay, and ultimately ended up being discharged home. The next case is a 36-year-old male who was found outside of a motel. He was jumping up and down on cars and breaking out car windows and hotel windows with a baseball bat. He came in with 6 police officers. He was exceptionally agitated, and he was his heart rate was exceptionally fast, his blood pressure was up, and he was sedated. He got admitted because he was so agitated. He required a moderate amount of sedation. In fact, he got admitted to the ICU, and he was positive for cannabis. So next slide, please. So if we talk about acute ingestions, several of those cases were all acute ingestions or intoxications. This happened in October this year and is probably one of the most concerning things that I've seen. We had a 12 and a 14-year-old kids come to the emergency department. They were acutely altered, hallucinating, and intoxicated. And we found out that they had bought this candy. And you can see the picture there where if you look at it, it's a nerd's rope. And you would have to really look at it. If you're a kid, I don't know that you would look. And up above the nerds part, it says medicated. And to the right-hand side, it says 500 milligrams of THC. Just going back to the joints of Woodstock or back to the joints of the early 90s, we had 1 to 3 milligrams. So these two kids separated this in half, and they each had 8 halves, so they ingested 250 milligrams of THC apiece. This happened just in October, and it turned out that they were getting the candy on a Snapchat. So they were taking Snapchat. The dealer was, what happens is the dealer identifies its location, the Snapchat disappears in a set amount of time, 15 to 10 seconds. These kids know where their dealer is. They go, they get it. This is what they bought. These girls were told that he was the owner of a dispensary and was willing to sell them that. I don't have any further police follow-up from that. But they had a prolonged ER stay. We had to use poison control services. And again, if you look at the concentration here, and if you're a kid, it really looks like a regular candy. So you could have an accidental ingestion. And we've seen this again and again and again. Next slide, please. This just happened recently. So after this ingestion happened, we did talk to the police authorities, and I let them know my concern was Halloween was coming up, and these candies really look like regular candy. And if these get into the Halloween bags, or if they get into kids, then we could have a potential big problem. And the other issue was they're doing it now electronically, so they're sending out messages via Snapchat or whatever other app you want, and they're identifying their location, and it's brief, and then the kids can go and get their stuff. This was a bust. This was in Louisiana, and you can see the products there. So these are exactly the Nerds ropes that we were looking at that our kids had. You can see that the Skittles packages look pretty much the same. The Sweet Tarts look the same, and you can see this is what they took when they found these people. This is all they got. It was guns, money, this candy products, the tinctures up on the top left, and then heroin and methamphetamines as well. So they also had a great deal of Suboxone. So this is up and coming. This is what our kids are facing. This is how easy it is for them to get. The school resource officers, I was going to include this and failed to put it in, but the school resources officers did a survey in 2017 or 2018, and where they looked at was when they took marijuana products off kids at school, they asked where they got it from. And the industry has promised that our kids will be safe. If we make it legal, they won't be able to get it from legal sources. But if over 50% got it from a friend legally, or got it from their who bought it legally, or got it from their parents themselves. And you look at that and you say our kids have ready access to this, so that it's very easy. And this is another demonstration of why it's so easy to get. Next slide, please. We talked about edibles and undergoing the first pass metabolism. These are some of the products available. You can see how these products are all made to look like candies. Several states are trying to push forward legislative laws that say you can't make it look like this. And clearly there's some trademark infringements when you look like the Magic Fruity Pebbles and the Hi-Chew, which is based off a candy that's called Hi-Chew. Or if you look at the brownies, and you can see if you were a kid how easily you would fall into using these products or taking these products. And again, there's dosing limits. So if you look at the Hi-Chew package, there's 300 milligrams of THC in that package. And if you're 8, you're not going to stop at one piece. So we've seen, and there's been reports of kids who take candy like this to school and then share it, and then several children in a whole class start coming down with symptoms, and we've definitely seen that here. So this is how easy it happens. This is part of my concern. Next slide. So some people will talk about like harm reduction. When I went to speak in Australia, they wanted to know about, well, could we like put this out and could we say, well, harm reduction? And I think harm reduction has to be done, but it's less desirable than just not having it. If you look at harm reduction, you're sending out this dichotomous message where you say, yes, let's all buy these products because we'll make a bunch of tax revenue. And then you say to the kids, no, it's not good for you. So it's hard because now the kids are looking at what their parents are doing, like the school safety officer resource study shows that many of these kids are getting it from their parents because their parents are under the impression that it's safe, it's harmless, it's natural, and it's a plant. And we know there are numerous studies that show that kids who use and the earlier use, the more likely are to have long-term psychosis problems as well as social and emotional problems. This was a study by George Wang et al., where they show that there's a yearly increase in the number of children's visits and the number of poison control cases. And what they're seeing, routes of exposure, inhalation, edibles, extracts, and capsule and pills. And if we touch briefly on the inhalation part, kids are vaping. We know that our middle schoolers, our 10-year-olds, 12-year-olds are vaping, and the cartridges look the same, whether it's nicotine or flavored oil or THC. So they're openly vaping, there's decreased smell. So this is very attractive for kids who are going to start using. And his conclusion was, despite multiple preventive measures, pediatric unintentional marijuana exposures continue to increase after 4 years of legalization, and this is still true today. So we're seeing increased exposure. Go to the next slide, please. When we talk about the cardiovascular and stroke symptoms, that's very profound. What we're seeing is there's several early papers out, and these earlier papers are done in the 90s and done with lower potency products, but they also say that there is a marked increase in the risk of cardiovascular problems, stroke, or heart attacks within the hour after smoking. And we see this is true again still. The thought is that it leads to oxidative stress, inflammation, and fibrosis, which will ultimately increase this risk of stroke and MI. I had I think he was in his late 30s, person just within the last 2 weeks who came in with an acute MI, and his only risk factor, not family history, not his personal history, was that he smoked daily or more cannabis. We know that long-term smoking will lead to peripheral vascular disease, arrhythmia, cardiomyopathy, and these are well documented. This is one of the most recent articles. It was the American Journal of Cardiology. Next slide, please. They feel that it serves as a significant contributing factor in MI for younger patients, and we have now changed it to ask this routinely in our histories when we take them from people having strokes or MIs. They say that there's up to a 17% increased risk of stroke in those younger than 45 with recent use of marijuana. The long-term complications or implications of this is that if you're young and having a cardiac event, you're become what we call a cardiac cripple or a cardiac patient for the rest of your life. And if you're having a cardiac event in your 30s, then it puts you at risk for the next 30 or 40 years of your life. So this is pretty substantial. We've had several people that present with stroke, and then we've had several people that present acutely intoxicated with a stroke-like appearance, and it turns out that it is just cannabis. My friend had a construction worker who was given a cookie at construction site, presented with acutely altered neurostatus and some weakness, and he got an extensive workup because, again, we know the risk factors are for stroke, and we can't say this is a stroke because they use cannabis, or this is a real stroke because they use cannabis and have vascular side effects. So you got a huge workup, a prolonged ER stay, and ultimately at the end of that, the patient had eaten this cannabis cookie, which we didn't get the history in the first place, and he was discharged, but not before a very large, expensive medical workup and prolonged ER time was done. Next slide, please. Vaping and pulmonary issues. This was a big issue right as we entered COVID time. We were talking about how there were dramatic lung changes with vaping. These are what the cartridges look like. These cartridges are very poorly regulated. The content in them is poorly regulated. They have made some thoughts, or some states have passed where you can't have flavored. It still is ultimately poorly regulated. What we saw in the 2019s was a host of younger people who ended up with extensive lung damage. Several died and several needed lung transplantation. And let's go to the next one. So the look on the left-hand side is what a normal lung looks like. The look on the right-hand side is what a vaping injury lung looks like. And I can also say at this point, it's also what COVID looks like. So it has very similar radiographic appearances. This has led to like what we call fibrosis or scar tissue building up in the lungs. And so a lot of these people, or several people at a very young age, in their 20s, and one was in his teens, ended up with a pulmonary transplant. And you can see or understand that the cost of having a transplant for this is going to lead to long-term medical expenses, and they're really significant. So next slide, please. So this is a look because we've been told that vaping is healthier. This is a look when we do a bronchoscope or look down with a light into the people's lungs. This is what it looks like. You can see normal lungs on the left, the smoker's lungs, and then look at the vapor. So we're said that this is healthier, it's better than smoking, but actually probably it's less safe. Look at the amount of redness or the inflammation in the lungs of the vapor compared to even that with the smoker. And I think part of that has to do with the very high temperatures at which you vape a product. And the kids or vapors know if you increase the temperature, you will vape more and you'll get a bigger high at the same time. So oftentimes it's several hundred degrees that they're using to vape, and you basically get a burn injury to your lungs. This will heal, but it heals with scarring. Next slide, please. So if we look at the CDC data in 2019, the report, this was their report as of February 18th in 2020. They had 2,800 hospitalized EVALI, so vaping acute lung injury cases or deaths have been reported. The culprit, one of the culprits was vitamin E acetate, and it's an oil-based problem or an oil-based chemical, and our lungs don't do well with oils. And over 80% of those listed in the CDC were vaping THC, and the media didn't report that part. But if you look at the CDC website and if you look at the studies that are being done, over 80%, and some studies, 87% had associated THC as what they were vaping. Next slide, please. Acute psychosis, and I know that this is happening on a daily basis. We had a 15-year-old who came in police custody because she was highly agitated and violent at home. She was caught smoking marijuana by her mother, and that is what precipitated this episode. The child became acutely agitated, became acutely violent, and required police to bring her in. When I went to the SAMHSA meeting, I was actually able to sit next to Dr. D'Souza, who is like an expert in the use of cannabis. And what he did in his studies was he actually injected THC into individuals and was able to show that normal individuals without psychiatric history or family history could be have acute psychiatric or acute symptoms that are suggestive of transient schizophrenia, like hallucinations, etc., by just injecting 5 milligrams of THC. And now we're talking about vaping 65 milligrams or eating a candy that has 250 milligrams. So we have literature out there that shows even the lower potency will cause acute transient schizophrenic-like symptoms. Next slide, please. Here's a few cases because what people need to hear is what I see. I had an 18 and a 19-year-old within the last 2 months who came for acute care. One had acute psychosis. Both of these people were homeless because of their drug use. They came to the emergency department. Ultimately, after an ED stay, a large workup, blood work, IV fluids, and medications, the 18-year-old improved. And at the end of the stay, when we talked to them about their drug use, there was nowhere for me to get them help. There was no place for me to send them, and there was no detox program because the few beds that we had in Pueblo were full, so we ended up just discharging them to basically back out to be homeless, and their families had cut them off. I had a 21-year-old male who presented acute altered mental status with his mother, who reports he had a seizure. When I did the tour at the dispensary here, the medical dispensary here in Pueblo, the owner indicated that, yeah, they would like to do smoke a lot and see if they could induce a green out, which is a blackout or a seizure. These, again, he had an expensive workup and went home. And I just talked to Lori Robinson, who runs Mom Strong, about the Thousand Oaks active shooter who killed multiple people in a bar, and his toxicology reports were released today. And this was a case of a young man who had acute recurrent psychotic episodes, had exhibited all kinds of psychiatric odd behaviors, and was very concerning for his mom. He'd been evaluated several months prior to this incident, but been discharged home because there is really a significantly limited amount of place to put these people, and ultimately had a psychotic break and had a shooting episode in a bar and killed multiple people, and he was killed himself. Next slide, please. If we look forward to what are we doing to our generations, we're going to talk about this study that's been up and running for about 2 years now. This is a large study, and it's being done by NIDA. And they enrolled almost 12,000 kids from across the country. They have a series of questions. They have a series of follow-up plans with these kids. And what they're doing is asking about the parental drug use, and then they will follow with their own drug use. They started with kids aged 9 to 11. This study, when we met with SAMHSA a year ago, had very little information, but even now they just presented this article in September of this year, and their conclusions were exposure to cannabis after you know you're pregnant leads to a decreased birth weight and lower intracranial volume, so meaning their brain size is smaller. They have confounded out other factors and came to this conclusion. They also said that after exposure after maternal knowledge of pregnancy, so if you understand you're pregnant and you continue to smoke during pregnancy, there is an association in offspring with acute or more difficult psychopathology characteristics. They have increased problems with tension, increased problems with thought, increased problems with social issues. Next slide, please. So I'm going to say a few cases from what I have seen. I saw a 5-year-old who came from the Head Start program here in Pueblo. She was acutely agitated. This is a 5-year-old who came in with police because she was became acutely agitated and started biting the other kids at the Head Start, started fighting with them, and the Head Start teachers weren't able to control this. They brought her in for us to evaluate. And this kid had what they termed explosive rage. She has never used drugs herself, but she was the product of drug-using parents and was living with her grandmother. And unfortunately, even though this kid does need long-term care, there was no place for her, so we ended up sending her home with her grandparents. The next case was an 11-year-old male who was also diagnosed with explosive rage disorder, and he got extremely angry, chased his grandmother and his sibling around with poultry shears in an attempt to stab them and kill them. The grandmother called the police. They got brought to the emergency department, and at that time the kid was fine, and he was, he said, I have these blackout rages and I don't know what happens. And so what we've seen, same with the shooter that happened in Thousand Oaks, these kids are having these acute rages. They're not using drugs, but they're the product of drug-using parents. And the hard part is saying, well, what drug is it? Because most of the time, these kids are the product of multi-drug-using parents. But we're seeing an increase. And when we look at Head Start, I met with the Head Start director of the area here, and they said 5 years ago, maybe one kid in a classroom of about 20 kids, and now they're seeing 6 to 8 kids who have extreme emotional problems, just like these kids. We ended up sending the 11-year-old home as well. And at that point, his grandmother is terrified, and so, as well as his sibling, but we just don't have the resources to get these kids in. So what we see in the emergency department, we can temporize problems, we can cool them off in the acute problems. There's no place to send them once we've done that. We send them home with families who are now kind of terrified, and I'm sure there's several in the audience who have had experienced this. Over the last 7 years, we have narrowing outpatient care, so we've had to have more we have less resources to send these kids to, and the long-term prognosis for these kids is exceptionally bleak. Assuming that we could get them the best of care, they still have a very difficult road to overcome because they're now basically genetically predispositioned to this. Next slide, please. Many of our inpatient programs have been closed. This is true for kids and adults. I saw a documentary not too long ago on HBO, and it's called A Dangerous Son. And they don't mention drug use, but you can see that probably several of these families had drug use, but it really depicts the problem that we have across the country with kids like the explosive rage kids and kids with the emotional issues that we can't take care of. And this is, I recommend that you watch this documentary because it shows it's not just an angry child, but it's an exceptionally angry child. It's a violent child. And you talk about the parents who are now very concerned. And this documentary also talks about the difficulty that each and every one of those family members had. And one of the people in the documentary is the mother of the Aurora theater shooter, who said, same thing, multiple issues where they had acute psychosis and no place to put them, no place to get help. So we're also seeing this scenario where we're sending them home on a regular basis. Next slide, please. At this time, we'll just take questions because we kind of cut it short. And I'm here to answer any questions that you have.
Wonderful. Oh, Karen, this has been so incredible and so helpful. And we do have some questions. So hopefully folks can hang on for just a couple extra minutes. Would that be okay?
Yeah, it's okay with me.
Excellent. We have a question about the cannabis medicine certification that you got. What did you learn and who and what organization made that available? You know, for example, the interactions you covered, taught in the certificate, etc.
So this was done through the University of Vermont Medical School of Medicine. And it was an online course. I guess it's open to anybody who wants to take it. I was the only, no, I think there were a couple other physicians, but I was clearly the only, probably not pro-cannabis person in the class at the time. We discussed the chemistry, we discussed the interactions, we discussed the plant genetics, we discussed the plants. They talked very little about the harms, and those were kind of ignored even when I brought them up.
Okay, thank you for that. Let's see. Oh, Dr. Christine Miller's on. Hello, Dr. Miller. She says, really great talk. Have you broken out the yearly costs to insurance companies? Of course, we all pay indirectly these costs, and the costs to your hospital that remain unpaid by insurance or Medicare or Medicaid?
That's like an awesome question, Christine. It's very, very difficult to say. So I'll say this, like breaking down the cost for hyperemesis for ER visits. It's really difficult to say how much the costs truly are, because what happens is, and what happened to me, the only complaint I ever had to the board in my career was about a patient that I labeled a cannabis use disorder or hyperemesis related to cannabis. And she was angry that I put that there, even though she admitted she used almost 2 grams of cannabis a day. She didn't feel that it was A, the cannabis, and B, she didn't feel like she had a problem with overuse or addiction.
Wow.
So she made a report to the board, and then then you know, obviously the complaint got dismissed, but it still have to go through those channels. So what I see is people will say acute nausea and vomiting or cyclic nausea vomiting, and then somewhere down the line we'll say chronic cannabis use. So it's very hard to actually really pinpoint these costs. I think several people have done it. Ken Finn has a cost study, but it's older. But because there's this reluctance to put down that diagnosis, because there's a disconnect in the patients when they have these symptoms, and a disconnect between their belief that it is actually cannabis induced, then it doesn't get recorded appropriately. So actually determining the costs, and the costs that aren't paid and the costs that are picked up by insurers is exceptionally complicated.
Yes, especially without them admitting causality. Okay.
Mhm.
A couple more questions. If anyone has any other questions, please send them. You mentioned about poison control services. If you have to call poison control for a child, what do they recommend that you do?
So basically, it is supportive care is what we do. So IV fluids, if they're exceptionally agitated, we can sedate them. If they're exceptionally sedated, we need to monitor their airway, give them IV fluids, that kind of stuff. So mostly there's no antidote, so there's no reversal. And the one thing I did learn when I did the course is that as opposed to opiates, the cannabis has very few receptors in the brainstem, and the brainstem is what keeps us breathing. And the reason why opiates kill people is because when they take too much, they stop breathing. Um, there are very few receptors in the brainstem for THC or cannabis products, and so people will continue to breathe even though they're excessively sedated. They're at risk for vomiting and aspirating and other kinds of problems, but they typically don't die of respiratory sedation, which is one of the reasons why the industry says it's safer than opioids or other products, because people don't, quote, die from cannabis. So
Got it. Okay. One question came in about when parents don't know the harms, as you mentioned, and in some cases, children are getting marijuana, teens, adolescents, from their parents who don't understand. Do the police get involved at that point if they present in the ER and it comes to light that the parents give them marijuana? What kind of response does the hospital do when they discover this illegal giving of marijuana by a parent?
So we involve DSS, but I think again, we're talking about a very limited DSS and a very non-committed public. So people have said it's not harmful. I'm going to say over and over again, we see younger people less than 21 who have acute cannabis intoxication. Literally nothing legally is done.
Okay. Dr. Randall, do you think the problems related to marijuana are improving in Pueblo or getting worse? What's been your sense where you live?
Well, we know that kids are using more, right? Our Healthy Kids survey shows that our youth are using more, our kids are using more. I think it's getting worse. I think now we're going to see offspring of chronic users who have all kinds of social and emotional issues, which will also lead to overburdening of the system.
What about children who you mentioned, teens who present with multiple times at the ER with psychotic issues? You mentioned giving antipsychotics. Do their brains heal every time, or will this eventually be permanent?
I think there's been a number of studies that say we can see long-term issues, and these children can continue to have acute psychosis without ingesting THC. I think we're not really sure where this high potency, really chronic use of THC, we're not sure where these are going to go. But from all the literature that's being published at this point, it doesn't look like it's going to go good places. It's not going to help these kids. And they may again develop long-term problems. There's been some long-term studies that show there's an increased incidence of psychosis. And I think we're going to see more of that.
Okay, thank you. Do you have a number of how many children who use marijuana will have uh, present to the ER, i.e., if you could put a number or a percentage on for people who are minors who come into the ER who have some sort of cannabis-induced psychosis. This comes from our Johnny's ambassadors in Ontario, in Canada, where, you know, 19-year-olds can get shatter, for example. Do you know how
Well,
many would
I
actually?
don't, I don't know how many, and I think it'll probably be years before we know. And I don't have a number. Christine Miller may have a number because she does the neuropsychosis,
Yes.
but I don't know the percentage of people who come to the ER have it.
Okay. How do you think we can get the public to care as much about children being exposed to marijuana as they do, for example, about their pets? Or do you even think this is possible?
Well, I have these questions about whether it's possible, but I think as I offer, any politician who wants to come with me and see the endpoint, all they have to do is spend a day with me, because this is not like it happens every once in a while. This is daily. This is every shift, every shift. And if they could look at these kids and see the hopelessness either on the kid themselves or their parents or their family members, and know that there's no resources, I think just 1 or 2 shifts with me would show them why we need to stop this. This is really harming our kids. It's devastating to the families that are involved, and I wish that they could see that. And that's what I think we have to do, is have to increase public awareness. And this, by means like this, what I thank you, Laura, for setting this up. And we have
Excellent.
to keep speaking out, and we have to be, I talk to my physician colleagues and I say, why don't you speak out? And the reality is that there's a lot of threats. There's a lot of concern for public appearance, and we need more people to speak out, because everybody acknowledges the harms, the police acknowledge the harms, and I think we're dancing around this very, very concerning subject, because if you talk to politicians, everybody wants it. So they're not going to say anything bad, even though they may personally be against it, but it's not everybody wants it. And unfortunately, when you speak out like I have, I actually had an article in the Epic Times recently, and somebody called the ER on a single day, probably over 20 or 30 times, to tell him he was going to come to the ER to kick my butt for lying about pot. So I think it suppresses a lot of people who would be willing to speak out.
Well, those of you listening to this recording, you just heard Dr. Karen Randall offer to spend a shift in the emergency room with any politician. And so please write to your senators, to your representatives, to your congressmen, and see if you can make this happen, especially in Colorado, but in any ER, and see if by raising our voices and continuing efforts like Dr. Karen Randall is doing to raise awareness, if we can move the needle a little bit and continue to spread the message about the harms of marijuana to our youth. Dr. Randall, this has been an incredibly informative, excellent presentation. And on behalf of Johnny's Ambassadors and everybody listening, we want to thank you so much for your time and your talent. And thanks to everybody joining. Thanks for being one of Johnny's Ambassadors.
Yeah,
we'll talk
thank
to you
you for
again
arranging this.
Thank you, Karen. You rock.
Thanks, you too. Bye.
Appreciate it. Take care. Bye-bye, everyone.